Guys, this is Dr. Rishi Desai, Chief Medical Officer at Osmosis. Thanks for being here with me again today. We've been doing this week on week, and we'll plan to be here again next week. I'm here to answer your questions about COVID-19. It's obviously in the news. There's a lot of stuff changing kind of week on week. If there's anything that you want to hear about or know about, type it in the chat, and I'm going to address it. So that's the idea. I wanted to get into a question that we got last week, which I didn't really get to fully kind of get to, and it's been on my mind, so I thought we'd just start with that. The question is, how can med students contribute to beating COVID-19? It's something that I think a lot of people kind of want to be involved in terms of raising the line to try to improve or increase healthcare capacity. That's kind of what I mean by saying raising the line, improving healthcare capacity. There's a few things you can do. So one, you can help faculty and healthcare workers with things like babysitting, daycare, pet sitting. These are all things that you can see I've got a bit of a cough myself. These are things that you need to be able to get done if you're a healthcare worker. And if you can help with that, that would be tremendous. So that's the first thing. There's also things like food shopping and delivery. There are folks at risk that aren't able to get out of their homes safely. If you can kind of take care of those needs, and again, the idea would be that you drop it off at their doorstep and you would leave. They would wait a little bit, go outside, grab those packages of food and other deliveries and bring them inside, so that they're basically not exposed to the outdoor environment, to anyone that's sick and have no way of getting ill. So if you could do those kinds of things. Other ideas would be to FaceTime and call those elderly folks. People are very lonely and very isolated. So if you have time, and that would, of course, start with your own circle of family, but you could expand that too and try to reach out to people that maybe you don't know, but would be willing to kind of volunteer to reach out to. And that would make a huge difference in someone's life. Other things, there are groups out there. My alma mater, UC San Francisco, was really proud to see that they were out there collecting PPE and dropping that off at local hospitals where it's desperately needed. So you might participate in an event like that. Now, if you're going to do that, you want to do it extremely carefully, because, of course, you want to make sure that you're not setting a bad example by congregating and socializing. So you want to do it really, really carefully and responsibly. And you can look at how those programs have been set up so that you can make sure that you carry on that model. So those are all things that you could do to participate in helping expand that healthcare capacity to raise the line. Other things you could do is to start with education. Educate your family, your friends about the importance of isolating. If we all isolated right now, that would dramatically affect, the number of cases that we're seeing. So that's something that you can do immediately in your own circle. Other things, make sure that you tell people how to manage their conditions. A lot of people in your friends circle and your family circle, I'm sure, have medical conditions. How can they take care of themselves so that they're not getting exposed if they have to go to the hospital? So if they have diabetes, make sure they have good diabetic control. If they have hypertension, they're taking their meds. Make sure they have enough meds, things like that. Other things you can do, you can talk to your school about teaching telehealth opportunities. Some of these older doctors have never done telehealth, don't really have exposure to it, and could use probably a tutorial in terms of getting onboarded, and maybe even just the support, the emotional support of kind of going and doing something new. That help that you offer that person is a multiplier, because that person now, if they're a telemed doctor, can affect many, many other lives. So you just helping that one person get onboarded could make a huge difference. Maybe even developing courses around how to do that. So ultimately, how to train your faculty and your peers on telehealth could be a huge thing. Other things you could do, we've set up a program and a pledge on Osmosis. Take the pledge. You get 3 free weeks of Osmosis Prime. That would be awesome. Good for you, good for us, to make sure that we get the word out and get you pledged to support, to do the things that we know you should be doing, like isolating, like educating. Finally, we actually set up a course on COVID-19. Take the course. Make sure that you know everything you're supposed to know about COVID-19. Maybe there are gaps in your knowledge. Fill those gaps in right now. You can go to osmosis.org/COVID-19 and you can take that course. It's free of charge. Go check it out. So these are all things you can do to get involved. I'm seeing tons of questions come in, so let me just jump right in and start answering them. I'm just going to read them off as I go through. So first question, are you immune from coronavirus after you get the virus? I love this question. I'll tell you why. When you get the virus, you typically get symptomatic from it. Usually it's going to be mild. Sometimes people have severe symptoms. that can be, let's say, 2 to 4 weeks. After those 2 to 4 weeks, if you recover, and we hope you do, then you get an immune response, and you can measure that immune response in terms of IgG and IgM in your blood. Early on, you're going to have an IgM response, which is kind of the early antibody. Later on, you're going to get an IgG response. That comes a little bit later. If you're IgG positive and you're totally better, that really does tell you that immunologically you're now protected. You're resistant in a way to getting COVID-19. You're through the worst of it, and now you're one of these special people that you could be exposed again, and you're not going to get sick. And so that's a great thing to know. And increasingly, that there's going to be more and more focus on that, because we're going to get more and more people recovering from COVID-19 and figuring out what to do. Maybe those people can go and give immunoglobulin in blood drives, and that immunoglobulin can be given to other people that are sick, that need it. Maybe you could be the one, if you're a healthcare worker, to do some of these high-risk procedures because other people may be more at risk, but you're not, because you're resistant to getting COVID-19 again. So these are things and reasons why I think that immunity is going to become more and more of an important thing that we'll talk about. Next question: is it true the virus lasts 8 hours in the air? The studies on how long it lasts in the air say that it lasts for hours and hours. Now, the key is that when they're doing these studies, they're trying to create micro droplets that resemble or kind of recreate what a sneeze or cough would do. They're not perfect, so it's not exactly that same length, but the studies are trying to replicate reality. Over time, these little particles settle down on objects around, so then it survives on objects for not just hours, but days. So it does survive in the environment for hours to days. Next question: can you tell how doctors can protect themselves from COVID-19? Truth is, it comes down to what you wear and how you are kind of wearing that stuff on your body. So N95 mask, you want to make sure you're clean shaven, you get a good seal, you're not getting air leakage around, so you're breathing through something that's very well protecting. You're also kind of covering the rest of your body. Remember, the key for this virus is this tiny T-zone. That's where it enters your body, right? It's not entering through your elbow, your knee, or your toe. It really just enters right here. And the way that we typically get it is we touch our face. In fact, we're touching our face multiple times a day. Let me rephrase that: multiple times a minute, multiple times an hour. It just multiplies out. So if you're constantly touching your face, you're really allowing that virus into kind of that very precious T-zone, that one weak spot we have. So that's the key thing I would tell doctors, is just be so meticulous and careful about how they're touching their face, and don't invite that virus in. Here we go. Next question: please discuss treatment modalities. So the biggest thing in terms of treatment is going to be what? It's going to be respiratory support. So everything from O2, oxygen nasal cannula, where you have kind of prongs in the nose and oxygen is kind of blowing in. It can get more severe. You might need some bag mask ventilation if it's kind of coming on strong. You might need to intubation with a ventilator. These are all things that you can do, all the way to ECMO, which is where another machine is essentially oxygenating for you because your lungs aren't able to do that. These are all the things that we can do to help your body get oxygen. At the end of the day, that's how most people are dying from COVID-19. You also can think about other things. So if you have mild illness, maybe you're breathing okay at home. That's not the biggest issue. Fluids, hydration is important to kind of help quell the symptoms. So making sure you're drinking enough fluids. If you can't do that, you'll go to the hospital, you'll get an IV. An IV is to help you get fluids. So those are the two key things that we do, is fluids and oxygenation. There are medications out there that are being studied, actively studied. You hear this about in the news all the time: hydrochloroquine, azithromycin, remdesivir. There are actually about 30 or 40 other ones, and actually we're going to be linking to that on our website very soon. You can go and look at all the different studies that are out there, all the protocols that are being looked at. There are tons of them. And the bottom line is that they're not yet out of FDA trials, so we don't know that they necessarily work, although there is some small evidence in small trials that maybe they work. They also have to be weighed out for safety and make sure there's no side effects from these things that might end up requiring dosage differences and things like that. Next question: how should we continue to study for USMLE Step 1? How can we help, since I'm an international medical graduate? If you're an international medical graduate, what I will tell you is that this disease is affecting all countries. So everything I said at the beginning of this 30-minute Ask Me Anything, go review that, because that'll affect your own country as well. So that's the first thing I'll say. How can you study for the exam? Well, I think the biggest thing is recognize that now more than ever, it's very clear that all this book knowledge is coming to the reality of patients that are coming to the hospital, that you're actually capable very soon of being effective on the front lines. So that to me is a very inspiring thing, that you can actually make a difference and save, not just a few lives, but really hundreds of lives with the knowledge that you have. Next question. Is it really a thing that coronavirus dies at 20 degrees temperature? There are lots of studies out there looking at what sort of temperature and humidity factors affect coronavirus. And what I will say is that it really is important to keep in mind that it's it's getting into the environment. It's true that there's going to be temperature changes in the coming months that might affect coronavirus. There's no hard data that we know that it will do that. What we do know is that there's a lot of disease, and when there's a lot of disease, it tends to continue to circulate. The numbers will continue to rise. So I have no reason to believe right now that temperatures alone will cause this to go down. Now, in vitro, in the lab setting, do higher temperatures cause the virus to survive less in the environment? Yes. Does higher humidity cause the virus to survive less in the environment? Yes. So we do know that coronaviruses in general prefer cooler, less humid conditions, but how that plays out in the real world remains to be seen. Next question. I think I have mild COVID-19. Doctor doesn't want to see me. Advised to stay home. Will COVID-19 go away without treatment? Great question. In the majority of cases, 80% or so of cases, people have mild symptoms and recover on their own. So yes, absolutely. 80% of cases recover on their own. And what you need to recover is essentially fluids. If you're having fevers, Tylenol. There was some contention about ibuprofen. At the moment, WHO supports the use of ibuprofen, so you can use ibuprofen, Tylenol for fevers, for symptoms like that. You can have cough drops. I'm actually sucking on a cough drop as I speak because I've got a little bit of a cough. I had fevers a few days ago as well. So I have some of these mild symptoms. I haven't been tested, but I'm presuming that I might have COVID-19 because these symptoms fit the category. And so what I want you to do is, if you're home having these same symptoms that I'm having, isolate yourself. Just make sure that other people don't get sick. In particular, that means washing your hands. You can still go outside, but make sure you have a mask on. Make sure that you don't get near anyone else, and that you're only doing it if you absolutely need to. I don't go outside unless I absolutely need to right now. And that just means if I have to go to the grocery store to get food, I go there, get food, come right back. So you isolate, isolate, isolate. So as much as possible, that. Is your immune system stronger or weaker after this virus? Well, think about it this way. In our life, we're exposed to lots of viruses, right? Most of us have gotten sick many, many times. And so the key thing is, just every time you get any sort of new virus, you're going to have an immune response to it if you have a normal immune system. And that means that in the future, that's one more virus that if you got again, you wouldn't get as sick. So as I was saying a little bit earlier, once people get over COVID-19, they're really resistant to getting COVID-19 again. So in that sense, I would say your immune system does get stronger after being exposed to a virus. In fact, that's the premise of a vaccine. The vaccines are basically exposing you to a killed virus, or maybe what they call an attenuated virus, and that just means that it's kind of a weakened virus, to kind of get your immune system ready so that when you see the real thing, you'll be completely protected against it. So same idea. Next question. Why does human immunity not defend us from COVID-19? How have other coronaviruses attacked the human body, and how come they don't cause the same problem? Great question. So, roughly speaking, about a quarter of all cough and cold symptoms are thought to be from coronaviruses. It's a family of viruses, not just one. And so typically our immune systems are pretty robust at taking care of it and getting rid of it. Now, what happened here is that we had a coronavirus that came from another species, and we're still trying to identify exactly what species. The thought is that generally they circulate among bats, and maybe there was some intermediate kind of animal, maybe the pangolin, that kind of brought the virus over and then brought it into human populations. But think of it this way. Did we really as a group ever see that virus before? No, right? Like, we had never really seen that virus. So it's a new one for us. So as a human species in general, we're not very immune to it because it looks genetically so different from the viruses we're used to. So our little antibodies that are always kind of around think, well, I've never seen this new virus before, and so you're not very immune to it. That's the first thing. So it's different in that sense. Secondly, what I'll say is that when you do encounter this virus, the genetics of this virus are such that it has kind of hit this sweet spot in that it transmits really quickly. So it has a unique protein that's able to kind of get into cells very, very easily and kind of get out and cause lots of transmission. It survives well in environments, so that's kind of a unique feature. Others do as well, but this one particularly, we think, seems to do a good job of surviving. And then finally, unfortunately, it's quite virulent, meaning it causes significant disease. It just doesn't kind of remain in the nose and the back of the throat. No, no, this one's going down into the lungs. It's sometimes getting into the blood, causing septic shock. So that's a unique feature too. So it's a unique virus. It's also a virus that we as humanity have never really experienced before. Next question: can you talk about folks who require ventilation? What percent of these people recover enough to get off ventilation? This is very, very hard to say in the current setting because what happens is that if you have a setting where, let's say, your healthcare capacity is quite high, you have people on ventilators, you're able to give them a lot of support, a lot of care. You can do all sorts of kind of really careful, nuanced tweaks to really get them off the ventilator. And when someone's on a ventilator, they're very tenuous, right? Everything about their physiology is extremely tenuous. So you have to really meticulously watch it. Now, let's say you don't have too many cases and you've got a lot of healthcare staff watching and caring for one patient. There's a good chance that patient will survive. Now, let's say you've got 10 patients, but one person, one doctor running around for 10 patients trying to take care of them. Very hard to be as careful, as meticulous, because you just don't have the bandwidth, right? In that setting, you see many more people die. So really, it depends on the setting and how overwhelmed your healthcare system is as to what percentage of people will recover enough to get off the ventilator. So what I would say is that it really depends on the country, the setting, the time, all those kinds of things. The death rate in China early on, in the first weeks of the pandemic, was around 16%. That was the mortality rate. Near the end, so let's say a month later, after China really jumped on it, a month later it was less than 1%. So the virus didn't change a lot in that 1 month. The human physiology wasn't changing a lot. What changed was healthcare capacity increased dramatically. So that's one thing I would just point out in terms of the percentage that would get off the ventilator. It really depends on healthcare capacity in a large part. Next question: technically, isn't this quarantine phase going to end when they make a vaccine, or hypothetically when everyone gets immunized from being exposed? It's a good question. So, playing this out, there are a couple of things that can happen. We might get a vaccine. The truth is that the timeline on a vaccine looks very clearly to be 2021. So we're not likely to get a vaccine in the next 9 months. If that changes, or if there's new news on that, that would be wonderful. I doubt that at the moment. We have no evidence that would suggest that, because these trials take months and months and months. The first phase usually takes 14 months, and we just started the first phase. So that's the first thing. The second thing I would say is that if you wait for people to just kind of all get it, what they call herd immunity, you're really talking about people, in terms of percentages, 40 to 70% of us getting the disease. 40 to 70% of Americans alone, let's say, getting the disease. Mathematically, what that works out to is over 10 million people getting seriously ill with it. 10 million people getting seriously ill, we just don't have the capacity for that. So these scenarios are really terrible. One is implausible because waiting for another year is unlikely to happen, meaning we need something now. Waiting for everyone to get it means that we're going to have tons and tons of sick people. So we need some other strategy. And I think that other strategy has got to be to reduce the number of people that get it by implementing strong mandatory isolation, meaning people can't leave their homes for a while, can't socialize for a while, and make the government mandate that. And some countries are doing that more than others, but that needs to be the federal mandate if we want to get on top of this. Next question: what's the relationship between ABO blood group and COVID susceptibility? So I actually did some reading on this. The blood typing data is very, very early, but essentially what they're looking at is whether there seems to be some predilection for some blood groups over the others. My read on it is that at this point it's almost not worth spending a lot of time on that, because we know that all of the blood groups do have plenty of patients that are getting the disease. So it doesn't seem like there's any one factor. What I think could be interesting is looking at some sort of predilection that would help with research efforts. I think that would be interesting. But at the moment, in terms of public health measures, there's nothing you would do differently for one blood group versus another. Other questions, here we go. How reliable are the COVID-19 test kits? Is there a better option to diagnose this disease from chest x-rays? And I'm going to add, or chest CT. We have a video on this. Again, if you go to our website, there's a free video on imaging findings with chest CT. Take a look at it. what they found, in short, is that in the early days of this outbreak in China, the RT-PCR, which is kind of the gold standard of how you diagnose it, was picking up 30 to 70% of cases early on. And you might be wondering, well, then how would they even know they were real cases? Because then they followed those people later and retested them. So what they found is that later everybody was kind of proven to have COVID-19, but early on you only caught 30 to 70%. What that tells you is that there's a lot of people that are missing that way. Now, these people, interestingly, also had chest CTs done. And those chest CTs had a great sensitivity. They were picking up 95, 97, 98% of these cases. So, what that tells me is that you can basically, when you're very suspicious of someone having COVID-19, you can take a chest CT, and if you see early findings and you're concerned that they have chest, COVID-19, you should assume that they do, even if the RT-PCR is negative. And that's important because you imagine, let's say you're in the hospital and you send a patient to the floor and you say, this person's really sick. They have some sort of viral disease, but you know what? Their RT-PCR was negative. So send them to the COVID negative floor. Now you've got doctors and nurses on that floor, respiratory therapists taking care of that patient. And then if you find out a few days later that actually they were COVID positive, all those people have been exposed. So it's a really dangerous thing to declare someone COVID negative if in fact later you find out they're COVID positive. So what I would suggest is in those settings, if the chest CT is positive, you presume they're positive, and then later you can try to do confirmatory repeat testing to see what happens. Okay, so next question. What are indicators to know that the patient is well and has recovered from coronavirus? So typically, you're going to have two groups of people that were exposed and were asymptomatic and they never knew, and maybe they only got tested because everybody in their family was tested because there was an exposure, or maybe they were tested because they're doing random testing, like let's say street side testing in South Korea. They were just kind of testing people as they drove through a drive-through. So there's all sorts of reasons a person might have been tested and was found to be positive, even though they didn't have any symptoms. The other group is a person that was pre-symptomatic. So maybe they don't have symptoms yet, but they're about to get symptoms. Now, what I would say is that you're recovered. That really applies to people that develop symptoms. And so they had symptoms, and then later those symptoms have all gone away. At that point, there is a chance that you're still shedding virus. I want to make that very clear. You can still shed virus even after your symptoms have gone away. But the amount of virus you shed is usually much, much lower and decreases day by day. Also, the way that you shed changes. So instead of having a drippy nose and a cough like I have right now, maybe you're not having those symptoms. So you're not getting that virus out there in the air and onto surfaces nearly at the same level. So the amount of threat or the risk of it goes down. So typically after you've recovered, you want to wait a few more days, and then you want to maybe ideally check that you really had a positive IgG response like we were talking before. And if you do, then you say, okay, no, I've recovered, I have an immune response to it, I have no symptoms, I'm really kind of ready to go back out there in the world. So that's what I would recommend there. Let's see, maybe one more question. This may sound silly. I love questions that start out that way. But if this is a virus and viruses normally need a host to survive, how is this thing surviving so long on surfaces? How long do they live on surfaces? Great question. So viruses do need a host cell to replicate. But I said replicate, not survive. They don't need a host to survive for, in the sense of like for a short while. So they can survive for a short while without a host. And that's the truth. And many, many viruses and many bacteria do survive without a host for a long time. Now, the key here is survival and transmissibility. So as I was saying before, they do survive for hours to days on different surfaces. Typically, you want to think about hard surfaces or porous or non-porous surfaces, and you want to think about soft surfaces or what are called porous surfaces. So non-porous or hard ones would be like your cell phone, your laptop keyboard, your refrigerator handle, the knobs on your drawers. Those are all things that are hard, non-porous surfaces. Those are the things you want to wipe down regularly and daily. The things that are porous, like your pillow, your blankets, your t-shirt, or your shirt, anything like that, that it survives and transmits off of for a much shorter period of time. It's much harder. So You should still wash those things on a regular basis, but not as frequently as the other one would be needed. So that's one key difference there. See if there's any other questions I can answer. Some studies note resemblances between measles and coronavirus. Can this explain the very few cases of children vaccinated? I'm not sure I fully understand that question, but I will talk about measles briefly. But measles essentially is an interesting virus insofar as it actually has a huge transmissibility. So there are elements from measles that we can learn here. For example, very famously, it's said that if you enter a room with someone with measles and you're on the other side of the room, you will walk home, leave that party or leave that room, and you'll get measles. And that famously has happened. In fact, the R naught for measles is 12 to 18, meaning for every one person with measles, 12 to 18 people get measles. For coronavirus, for COVID-19, it's closer to 2.5. So much, much less transmissibility, but on the same level of kind of thinking in terms of the fact that it does spread, it does linger, it does live in, live on surfaces and so on and so forth. Okay, big question here. Can you talk about treatments and drugs available? So we talked about kind of general measures, IV fluids, oxygenation, things like that, ventilation. So putting that aside, what are the treatments or the drugs that actually treat COVID-19 disease? So there were early on a number of medications that were looked at. The ones that have gotten the most attention are protease inhibitors, that are often used against HIV, remdesivir, which is a drug that's used against Ebola, and chloroquine or hydrochloroquine used against malaria. That last one in combination with azithromycin. So having said that, there are many others that are being looked at, probably on the order of 30 to 50 other drugs, combinations, steroids, natural killer cells, all sorts of things that are looked at to see if they would be effective. And we have that list. We're putting it together. We're going to post it. So check out our resources for that. But having said that, these first few are in phase trials, phase 2 trials, phase 3 trials, to look and see how efficacious they really are going to be. The other thing you want to look at is toxicity. When you look at these medications, what dose do you actually need to use? And is that dose going to be safe for the duration you need to use it for? So these are all things that are still under investigation right now. There are protocols that you can use called compassionate care protocols, where if you have someone that's really, dying and there's no other alternative, you can try to use some. You can use some of these medications. So that's something to keep in mind. I said dying and then I started coughing. Apologize. There we go. So what I want to say is that essentially, when you're looking at these protocols, they exist, they're out there, they're being used right now. The drugs themselves are, again, in phase 2, phase 3 trials. Let's all follow them closely. We're going to be putting updates up for you. In addition to that, there's also the fact that we need rapid testing to know who has it and who doesn't. Those are also changing quickly. So RT-PCR is one, but also rapid tests available today that are being developed as well. Let me see what else we got here. Okay, so I apologize for my cough. It's sounds worse than it is. Okay, so one set of bullets here I want to leave you with. We've partnered with Coursera to bring you the COVID-19 course. It's up, it's live, it's got more content. It's actually worth 2 CME units. If you want to claim that credit, go do it right now. Do your part, pledge to raise the line and flatten the curve. You can get 3 weeks of Osmosis Prime today if you do that. Don't forget to care for your own mental and physical health. We're going to actually on Saturday do a live yoga session. I want you to meet me back here next week. You can check in on my health, obviously, but also just meet me back here to answer more questions. And then finally, we've got all these resources. If you're trying to figure out where all this stuff is located, just go to one place, which is osmosis.org/COVID-19. Check it out. And ultimately, we have your back. I want you to be well, and I'll see you again. Take care.